Hello class and welcome to Business 80, Medical Terminology and Anatomy. And this is Chapter 6, the Cardiovascular System. So let's get right into it. All right, so the cardiovascular system, cardium, Latin, referring to the heart. The pericardium is a sac that surrounds the heart and it helps to protect the heart, okay? And if you notice on the slide, it says pericardium derives from the Greek word meaning around. So if you just remember peri, P-E-R-I, is always surrounding something. So the pericardium is a sac that surrounds the heart, okay? So that's the protection layer, okay? The pericardium has an inner layer and an outer layer, okay? So the inner layer is the visceral layer, and then the outer layer, and that layer forms the epicardium, and then the outer layer is the parietal layer, okay? Three heart wall layers: epicardium, myocardium, endocardium, okay? So if you can remember those, epicardium, epi, E-P-I, means on, or oftentimes medically is saying, or meaning above something or on top of something. So the epicardium is the outermost layer of the heart layers, and then the myocardium is the heart muscle itself. Remember, MY refers to muscle, so myocardium is heart muscle, and the endocardium is the innermost layer of the heart, okay? The heart has two chambers, the atria, two upper chambers, the atria, and then two lower chambers, the ventricles, okay? And then we'll talk a little bit about that. The atria, the first chambers in the heart to receive blood before it empties into the ventricles, and then the ventricles pump it out to the rest of the body, like to the lungs and to the rest of the body, okay? So the atria on top kind of holds the blood, sends it off into the ventricles, and then the ventricles disperses it throughout the rest of the body. All right. Let's see. Blood flow through the heart. I'm not going to have any questions on this on the exam. I don't particularly care if you can remember the blood flow, but I do like this kind of definition of how the blood flows through the heart. So it says the blood is carried from the right atrium via the inferior vena cava and the superior vena cava. Okay, so inferior vena cava being below, superior being above. So right atrium, okay, to the right ventricle. It says when the right ventricle contracts, blood is ejected into the pulmonary artery and out to the lungs. Okay, so remember, the ventricles are what sends the blood from the atria to the ventricles, ventricles to the lungs and the rest of the body. Okay, so right atrium to right ventricle through the pulmonary artery out to the lungs. Blood returns to the left atrium from the pulmonary veins, and then the left atrium empties into the left ventricle, and then the left ventricle contracts and pumps blood into the aorta to the rest of the body. So it's kind of like this circular kind of system, okay? So there's a good diagram. The cardiac conduction route, I kind of like this one because you're going to need to remember this one. The sinoatrial node, the SA node, oftentimes considered the pacemaker of the heart, or the natural pacemaker of the heart. So it's what sets the heartbeats, okay? So the sinoatrial node, pacemaker or natural pacemaker of the heart. Remember that, okay? The heart valves, two atrioventricular, tricuspid and mitral valves, and two semilunar or pulmonic and aortic valves. Okay. So the tricuspid valves, just so to make this a little bit more clear, the tricuspid valve separates the right atrium from the right ventricle. Okay. The pulmonic valve separates the right ventricle from the pulmonary artery, and then the mitral valve separates the left atrium from the left ventricle. Okay, so tricuspid is on the right side, and then the bicuspid or mitral valve is on the left side. Okay. All right, the cardiac cycle. So the cardiac cycle, and it says it's marked by the beginning of one heartbeat to the beginning of the next. That's one cardiac cycle. And it does consist of electrical and mechanical events. Okay, we'll kind of delve into this one a little bit deeper here in a second. But that cardiac cycle, one heartbeat, is marked from the beginning of a heartbeat all the way through to the beginning of the next heartbeat, one cardiac cycle. That's a complete cardiac cycle. Okay. Now, there are two phases of the cardiac cycle, which I think are very important, in particular if you're checking blood pressure, because blood pressure as a vital sign is based off of basically two points: the systolic or systole and the diastolic or diastole. Okay, so the systolic phase, the ventricular contraction phase, that's kind of when the heart muscle or the arteries are contracted, okay, and they're being kind of squeezed, so they're under pressure. And then the diastolic phase is when it's back at relaxation, okay? So ventricular contraction, systole, okay? And if we were checking blood pressure, that's the top number. I always like to say S over D, systolic over diastolic. So that's that contraction phase. And then the diastolic is when the atria contract and the ventricles fill, and that goes back to a relaxation state, okay? So that's kind of how I like to term that one. Speaking of that, when we talk about vital signs are probably the question that I would ask you is, what are the four main vital signs? Okay, vital signs are directly related to the cardiovascular system. So when we talk and the respiratory system. So when we talk about vital signs, there are four main vital signs here: blood pressure, pulse, the number of beats per minute, respirations, and then we throw in body temperature. So those are the four main vital signs. So height and weight are not vital signs, although they're taken at most visits. When we assess vital signs, we may do height and in particular weight at visits. Those aren't vital signs. Blood pressure, pulse, respirations, temperature. Okay. All right. Probably on the bottom of this slide, the one thing I like to talk about is arteries and veins. Best way to remember which one does what. Arteries, away. So think of arteries beginning with an A and away. Arteries away. Okay, carry blood away from the heart. Okay, veins carry blood back to the heart. Okay, so that's probably the best way to remember that. All right, and then capillaries are like very fine hair-like vessels. Okay, they're very fine. We do capillary punctures and phlebotomy whenever you do a finger stick for things like glucose or instant point of service monitoring for a CBC or cholesterol, diabetes. When we poke a newborn on the heel to do something like a PKU, those are capillary punctures. Okay, those fine hair-like vessels. All right. All right. Let's see. Physical terms. We've hit vital signs, pulse, beats per minute. Okay, heart beats per minute. Blood pressure. And blood pressure and pulse are different. When I teach vital signs in classes, sometimes I'll ask people, when we put on a stethoscope and we're listening with a blood pressure cuff, which is a sphygmomanometer, say that 20 times, sphygmomanometer, I'll ask people, what are we actually listening to? And people oftentimes will say, well, we're listening to the heartbeat. Well, if you think about this rationally, why would we listen to the heartbeat if I can palpate a pulse? Okay, or I can listen to an apical pulse on their chest with my stethoscope. Why would I put a stethoscope here and inflate that cuff and then listen to the heartbeat? We're not listening to the heartbeat. We're not getting beats per minute when we're doing blood pressure. Okay, we're listening for those Korotkov sounds, which is the last bullet on this slide. Okay, sounds that are auscultated or heard. Auscultation is to listen or to hear. When we hear the blood pressure, we're listening for the blood to hit against this brachial artery wall, and that's what we're listening for, the systolic or under pressure number, the top number, the S, and then we're listening at the end for the last sound that we hear, or the last lub-dub sound that we hear, and that would be the diastolic pressure, the D, S over D, systolic over diastolic. So we're listening for, when we're doing blood pressure, the blood that's hitting against the artery wall, the pressure that's forcing that blood against the artery wall. So it's not the heartbeat we're listening to. Okay? So we kind of hit that one. Pulse pressure is a good one. It says the numerical difference between the systolic and diastolic blood pressures. What that means, if you think about this, we traditionally consider normal blood pressure to be 120 over 80. That's a 40-point difference between the two. Okay? That's typically normal. Okay? 40-point difference between the two. Okay? That would be the pulse pressure. Sometimes this is important to note that there may be pulse pressure differences, and this could be a significant finding possibly, or prompt a provider to do additional testing on a patient if that pulse pressure is in particular less than 40. Okay, so if we had something like 120 over 110, now we only have a 10-point pulse difference. So typically 40 is about where we normally lie. So somebody that maybe is 140 over 100, that would be a normal pulse pressure. It would be hypertensive. It would be too high, 140 over 100, but the 40-point pulse pressure difference would be normal. Okay. The stethoscope is the instrument used to listen, to auscultate blood flow, other sounds, abdominal sounds, breathing, lung sounds. Okay, we use the stethoscope for that too. Okay, physical exam abnormalities. These are some of the things that we might run into that are abnormal when we do physical examination. Murmurs, okay, a fluttering heart sound. Murmurs are fairly common. Not all murmurs are dangerous to a patient. Some murmurs are very benign. Okay, so they're not harmful. But whenever a murmur is noted, further investigation into the cause of that murmur is warranted. Okay, bruit is, and that's how you pronounce that, bruit. Abnormal sound heard over a blood vessel. That's called a bruit. Cyanosis, blue coloration, especially when we're not getting enough oxygenated blood. Pallor is a pale color or very light color. Okay. Edema is swelling or an accumulation of fluid. When we talk about, I think we're going to discuss pulmonary edema here in a second. Diaphoresis is a fancy term for profuse sweating or perspiration. Okay. And then angina or angina pectoris is chest pain, usually with a cardiac origin. Angina doesn't necessarily, somebody could have like chronic angina, and it's not harmful. But again, if somebody's having chest pain, and we always are going to evaluate the cause of that chest pain. Okay, so it may or may not be a sign of some underlying cardiac problem. Okay, some of the diagnostic tests that we do a fair amount of blood tests. Partial thromboplastin time, that's a good one. So that's in conjunction oftentimes with a prothrombin time. Those evaluate blood clotting factors or fibrin clot formation. Okay, cardiac enzymes, probably the big ones, or the big one for me would be the creatine kinase, or CK. That's the very common enzyme test that looks for evidence of heart damage. Okay, a cardiac troponin is a good one. It measures a protein called troponin, and troponin Usually elevated levels of troponin indicate that a myocardial infarction has occurred. Myocardial infarction, or an MI, is a heart attack. Okay. Let's see, other diagnostic tests, a cardiac cath to inject contrast into a vein so that we can take pictures, so that we can do like angiocardiography or an angiography, where we can take x-rays of blood vessels in the heart chambers. Okay, thallium stress test, very common. So it says radioactive contrast dye is injected into the patient, and then the patient would walk. Oftentimes it's very slow walk that we build up to more of a light jog on a treadmill, and this can help to diagnose coronary artery disease. Okay. All right, some of the invasive tests that we might see. So invasive, what's the difference between invasive and non-invasive? Invasive is, for the most part, whenever we're going inside the body or cutting the body to go inside the body. Okay. Non-invasive is when we don't have to do that. Okay, when maybe we're just doing examinations on the outside. All right, or doing examinations of the internal structures, but not having to physically be inside the body. Something like an electrocardiogram, an ECG or EKG. All right, that would be a non-invasive procedure, an ECG. Invasive procedures, excuse me, like the electrophysiologic studies for conduction issues, to look for electric conduction. Those would be invasive. Pericardiocentesis, the surgical procedure where fluid is aspirated or taken out and withdrawn from the pericardial sac, that sac that surrounds the heart. We may take fluid from that for examination to see if there's some underlying heart disease. That's invasive. Okay, and of course your ECG, probably being one of the more non-invasive procedures that we do fairly frequently. A regular stress treadmill, not a thallium, but just a regular stress treadmill, where they basically hook you up to an ECG type monitor to monitor your electrical activity while you're under stress, walking and then going to that light jog. That would be non-invasive. Okay, some disorders of the heart. A lot, right? Cardiac arrhythmias. What is an arrhythmia? It means lack of normal rhythm. Okay. A at the beginning as a medical prefix is without. So this an arrhythmia is without normal rhythm. Okay. So atrial flutter, atrial rate of 250 to 400 beats per minute. Now, if we go back to the pulse, the normal pulse rate for an adult is anywhere between 60 and 100. Okay, so there's 40 beats to kind of play with. The average adult pulse, or beats per minute, is 72. So an atrial flutter that increases the beats per minute to 250 or higher is fairly significant. Typically is telling us that there is some underlying cardiovascular issue. Okay. Two terms here. I like bradycardia or bradycardia. I pronounce it bradycardia. Bradycardia and tachycardia. Bradycardia is a heart rate less than 60 beats per minute. So again, for an adult, 60 to 100 is normal. So bradycardia, slow heart rate, less than 60 beats per minute. Tachycardia is elevated. Tachy means elevated. So tachycardia would be a heart rate of more than 100 beats per minute. Okay. Now, both of those could be totally normal potentially for a patient, but they could also be abnormal or signs of an underlying problem. This is why when we have those as a diagnosis, then we have to investigate why we have bradycardia or tachycardia. And again, it may be totally normal. Okay. Ventricular tachycardia, probably a good one. It says high rate and rhythm with wide QRS complexes. So these are, when we talk about the EKG, PQRS and T, and then sometimes U we're looking at an ECG, a wide drawn out QRS complex indicates ventricular tachycardia, okay, rapid ventricular contraction, and that's potentially a deadly problem, okay. It's a potentially deadly arrhythmia that can kill somebody, okay. Let's see. And then paroxysmal atrial tachycardia. Let's talk about that for a second. It's an arrhythmia in which the atrial and ventricular rates are regular and exceed 160 beats per minute. This arrhythmia is typically characterized by sudden onset and then termination. So a quickening of the pulse rate to 160 beats or higher, but then going back to under 100, somewhere between 60 and 100 fairly quickly. Sudden onset, no real reason for why it happens. That would be paroxysmal atrial tachycardia. Okay, cardiac complications. Got a bunch of stuff here. Aortic aneurysm. Okay, an aneurysm is what we call an outpouching, or not a growth, but like almost like a swelling of something that goes beyond where it normally should be contained to. Okay, so an aortic aneurysm is an outpouching or stretching or bulging of the wall of the atria. Okay, that can be very serious. Cardiac arrest is when the heart just stops abruptly. Okay, obviously when there's no blood pressure or pulse, absence of circulation, cardiac arrest. This would be the situation where we might perform CPR. Okay, cardiac tamponade. Probably best way to describe this: cardiac tamponade, blood or fluid fills that pericardial space, so that sac that surrounds the heart. Okay, and then it presses and it puts pressure on the heart muscle itself. Okay, and then that obstructs return of blood if we have that pressure that's built up in the sac that surrounds the heart. Okay, cardiogenic shock is also called pump failure. Okay, and it says it results when more than 40% of the heart muscle is damaged from a myocardial infarction. When you have a heart attack, when you have an MI, usually what happens is, that heart muscle has weakened, and some of the heart muscle dies off and it's no longer usable. So cardiogenic shock can happen when more than 40% of the heart muscle has died. Okay, as a result, the heart can't pump effectively or efficiently, can't help pump blood through the rest of the body efficiently. Okay, let's see. Hypotension is an abnormally low blood pressure. Okay, usually we say, remember that 120/80 is considered to be somewhere in that normal range for most adults. Anything below like 90/60, if it's below that, that would be considered hypotension. Again, can be very serious, but can also be normal for an individual. It depends on the individual. Okay, so again, one of those things where a provider is going to do additional testing to determine whether there's some reason for somebody's blood pressure to be that low, and it's a reason that we need to investigate into trying to treat. Okay, pulmonary edema, an accumulation or excess of fluid in the lungs. Pulmonary edema. Remember that edema is basically swelling of because of fluid buildup. Okay, and then ventricular aneurysm is an outpouching of the ventricular wall. It's most commonly seen in the left ventricle. Okay. All right, congenital heart defects. Remember, congenital is from birth. Okay, so some of these, actually the majority of these are very serious. So an atrial septal defect is an abnormal opening between the atria. Okay. Atrial septal defects. Actually, this should be a ventricular septal defect on that one. The second one, abnormal opening between the ventricles. Sorry, that's a typo on there. Okay. So it says, like on that one in your textbook, it says a ventricular septal defect is an opening between the two ventricles that allows blood to shunt between them. Okay. Um, so that's not good. All right. So depending on the size of that opening, it says a spontaneous closure may occur, and if the closure doesn't occur, right and left-sided heart failure will occur along with cyanosis, or that bluish color. Okay. So very serious. Okay. Those two things are very serious. Okay. I will take care of that typo after this video. Okay. Let's see, disorders, degenerative heart disease. These disorders, these are the types of things that you see in particular in family practice. We see a lot of these disorders, very common, right? Coronary artery disease, or a narrowing of arteries. It's usually caused by atherosclerosis, or plaque buildup in the arteries. Okay. And we have many others, myocardial infarction or heart attack, hypertension, abnormally high blood pressure, heart failure or pump failure. Okay. Inflammatory heart disease, inflammation caused from injury or tissue destruction, which could potentially happen from something like an MI, where that heart muscle tissue is no longer useful. Endocarditis, which is usually bacterial or fungal infection of the heart. Okay, myocarditis, which is inflammation of the heart muscle, and that can be both acute or long-term, chronic myocarditis. Pericarditis, an inflammation of the sac that surrounds the heart. Okay, and one of the notes in your text says, in constrictive pericarditis, the pericardium thickens. So that sac thickens and constricts the heart's ability to pump, probably causing heart failure. Okay, and then rheumatic fever, childhood disease that's usually caused by strep bacterial infection. Okay, let me go back to that. Which is important. Rheumatic fever. Let me comment on that. Caused by strep infection. That's why, whenever a parent calls, and in particular, every family practice I've worked in, we always take childhood illnesses very seriously. No matter how much we might think there may be nothing going on, we still want to get kids into the office. This is one of the reasons why. Untreated or undiagnosed strep could lead to rheumatic fever, which could actually cause permanent heart valve damage going forward for a child. So I tell parents, whenever a kid's got a sore throat or whatever, call us. We probably want to get that child in, make sure that they don't have strep, because it could affect them longer term. Not a lot of patients know this, not a lot of lay people know this, but that's one of the reasons why we typically urge parents to bring their kids to the office. Okay. All right, vascular disorders. Different vascular disorders. I probably pay a lot of attention to aneurysms. Okay, it says weakening of a wall of an artery. Aneurysms can be very serious. Okay, and then thrombophlebitis. Thrombophlebitis is one that definitely pay attention to. That's very serious. Is a thrombus formation or a clot formation in a vein. Thromb is clot. Okay, so a thrombus is a clot. Phleb, Phleb, is vein, and then itis is inflammation. Okay, so when we put those terms together, okay, we've got a suffix and we've got two roots, right? Thromb or thrombo, clot, phleb, vein, and then itis is an inflammation of a vein caused by a clot. Okay. Let's see, what else? Stenosis. Stenosis is a narrowing. So anytime you see stenosis, it's a narrowing of whatever we're talking about. So when we talk about aortic stenosis, it's a narrowing of the aorta. Okay, mitral stenosis is a narrowing of the mitral valve. So anytime anything narrows, typically, common sense says if it narrows, then less can get through in an efficient manner. Okay, so these are very serious because they can lead to things like insufficiency. So if you had aortic stenosis, then you would have aortic insufficiency. It doesn't sufficiently or efficiently pump blood to the ventricles to get to the rest of the body. Okay. Different treatments. Drug therapies are very common. So we have invasive treatments, non-invasive, drug therapy type treatments. A lot of these treatments target blood pressure. So when we look at something like a calcium channel blocker or beta blockers, those typically are used for treating hypertension or high blood pressure. We've got other, arrhythmic drugs. When people are having arrhythmias or abnormal or absence of normal cardiac cycles, then we would use an antiarrhythmic. Antianginals, something like nitroglycerin to treat or prevent cardiac pain, very common. Thrombolytic therapy to prevent blood clots from happening. Okay, so or used to dissolve blood clots is very common drug treatments. Surgical treatments, things like ablations. Okay, that's a good one. It's a surgical procedure in which a small selected area of the heart is destroyed to treat refractive tachycardia. So this is a purposeful treatment. Oftentimes I say, an ablation is to destroy, possibly to thin out an area of the heart to prevent it from being tachycardic or having that increased more than 100 beats per minute. Okay. Coronary artery bypass or a CABG, CABG. That's very common. Very common surgery. We also have minimally invasive surgeries that correspond with coronary artery bypass, but usually occluded arteries or arteries that have been either really stenosed or have plaque buildup in particular, what we might do is replace sections of those arteries with some other tissue, okay, or some other vessel. So commonly, the most common is the saphenous veins in the leg. We might use a piece of the saphenous vein and replace a piece of a blocked artery and reroute that artery. Okay. Let's see other treatments, advanced things like advanced life support, CPR. That's a good one, and I like the definition: recognition and treatment of acute or sudden onset cardiac emergencies. That would be something like CPR, which is the next one, right? Cardiopulmonary resuscitation, basic life support. Other advanced cardiac life support things might be something like defibrillation. Electric shock, and it says it's used to terminate lethal arrhythmias, abnormal rhythms that could kill you. That's what defibrillation is to try to terminate that arrhythmia. Okay. Pacemakers, very common, used for electrical impulses to generate that cardiac rhythm. Those may be used for damage to that sinoatrial node, the natural pacemaker of the heart. Okay, valve replacement. We can do some valve replacement, and either with a natural human valve, as in like a transplantation, or with a mechanical valve device that can be implanted and replaced like a mitral valve. Okay. Stent, mechanical device inserted into an artery to hold the lumen open. The lumen is like the interior diameter of the vessel. We may put a stent in, which basically balloons open and keeps that vessel open so that blood flow goes through that. Okay, so that's what a stent is. Contrary to popular belief, Um, I had a cardiac surgeon one time that told me that a lot of his patients believe that placing a stent cures their problem. You know, if you have an artery that's very narrow or maybe is plaque filled, putting that stent in there to open that back up is the cure to that problem. And what he said was, it's not a cure. It really only alleviates symptoms, possibly things like angina, like chest pain, due because blood isn't flowing through that artery properly. Stents are not replacements, not curative in nature. Many people have to have multiple stents placed. So typically what I say, and I've got a good friend that had this happen to at 52 years old, had to have a stent placed. And he literally changed his diet and went to a vegan diet and doesn't eat any animal products at all. And he's seen a tremendous, not only did he lose weight, but he saw a tremendous increase in his, or decrease in his cholesterol numbers, and an increase in his fatigue had declined, and his, just his whole physical life became better because he did that change. He did that change in order to hopefully prevent, plaque buildup in an artery and having to have a stent placed later on, or having multiple stents. Okay. We talked about valve replacement, so I think we're good. I'm trying to think of anything else that I might be able to add to this, but probably not. So I look forward to seeing you next week for Chapter 7.